Good morning, everybody, and thank you for attending today. My name is Mark Driscoll. I'm the program manager for the Preventive Health Program for the Ohio AAP, and I have the privilege today of introducing our speaker. Dr. Jessica Foster is a developmental behavioral pediatrician and is the director of the Division of Developmental Behavioral Pediatrics in the Neurodevelopmental Science Center at Akron Children's Hospital. She also serves as medical director for Akron Children's Family Child Learning Center. She is active with the American Academy of Pediatrics and is a current executive committee member for the AAP Council on Children with Disabilities. She also serves as council liaison to the AAP section of Developmental Behavioral Pediatrics. In the past, she worked as Ohio's Title V Children with Special Healthcare Needs Medical Director at the Ohio Department of Health. Prior to her role at ODH, she worked for Nationwide Children's Hospital and Neisinger Center at The Ohio State University. She completed her pediatrics residency, developmental behavioral pediatrics fellowship, and Master of Public Health at the University of Kansas and is still a Jayhawk at heart. She is the proud mom of 3 boys and is officially the shortest member of her tall family. So without further ado, Dr. Foster.
All right, thanks so much. I'm happy to be here with you all today. This is a great topic. I really enjoy talking about behavior in young children. So happy to be here with you to do this. I don't have any relevant disclosures and have considered the Ohio AAP DEI standards in preparing this presentation. And I do welcome any feedback or suggestions if you should have them following the presentation. All right, we have a lot to cover today. We are going to focus on young children, so ages 2 to 6, who might be presenting with behavioral challenges. Hopefully, we're going to help you understand how to distinguish between what is simply a problem behavior that might need a little help versus actually a presentation of some sort of a disorder, whether that be ADHD, or other emotional or behavioral disorder, or even neurodevelopmental disorders. We'll talk about how there can be a lot of overlap. And then hopefully you'll also pick up some nice little tips related to parenting and behavior management strategies that you can use to coach your families in your practice. All right, so quick epidemiology to kick us off. So we know that about 17.8% of children in Ohio have a special health care need. Children and youth with special health care need is that's federal language, it's a federal definition, and it's a pretty broad umbrella. So kids with special health care needs might have diagnoses like asthma, or congenital heart disease, or maybe ADHD, autism, CP. So these are definitely kids that are in your practice. We also know that the prevalence of these various conditions is increasing. So developmental disability, in fact, that prevalence increased from about 7.4% to 8.6%. And then emotional, relational, and behavioral problems are also relatively common. Again, depending on the study and the population you're looking at, prevalence rates can vary from 7 to 10% in preschool children. And in that statistic, we're really talking about disorders in preschool children. So we also know that behavior and emotional problems that don't meet full criteria for an actual diagnosis are even more common. And you will see those present on a regular basis in your practice. So that is part of what we're going to focus on today. So I've already mentioned, and you'll hear this theme, that there is definitely overlap between developmental and behavioral problems. So that's an important key point to take home. Another important key point is the association of family psychosocial risk factors with behavioral and emotional problems, and the importance of identifying and addressing those factors if we're going to do a good job of supporting a family with their children's behavior. And then, just like anything, if we detect the problem, then we need to be prepared with what to do next. So, again, hopefully, this talk is going to give you some really nice tools to address these concerns. All right, so we have a little case that we're going to follow. Hopefully, this will help the content be a little more engaging for you. So, Joey is a 3-year-old boy who's presenting for his well child check. Mom is worried about his behaviors. You are running behind today. You can hear yelling through the closed door. When you enter the room, mom is clearly stressed. Joey is climbing on the table, and the contents of your exam table are on the floor. I am guessing this has happened to you before. So, what would you do next? A. Tell mom firmly that she must get her child's behavior under control before the visit can proceed. Or B. Insist that they reschedule to another day. You don't have time for this, and Joey's behavior is unacceptable. C. Take a deep breath, apologize for running behind, calmly greet Joey, help to redirect him to the toy he brought with him, and then listen actively to mom's concerns. So obviously I'm being putting in a little humor here. But in all seriousness, if you don't have a handful of strategies in your back pocket, if you're not sure what next steps to take when kids present with behavior problems in clinic, then you are more likely to maybe unintentionally respond more like A and B, when of course C is the approach that we'd like for you to take. All right. So mom tells you that Joey has challenging tantrums. He's never still. He's aggressive towards his parents and siblings. She has a hard time understanding him. When they don't understand him, or if he's not getting his way, he gets frustrated fast. And that's when the behaviors start. Mom wants to know what to do. She's worried about ADHD or maybe autism and wants to know if he needs additional evaluation. So I'm going to pause just for a second and let you think a little bit about what next steps you might want to take or next questions you might want to ask. All right. So, if we're going to sort out and have a good understanding of what's going on with the behaviors that present, we need to take a good standard approach to assessment of the problem, just like everything else that we do in pediatrics. In the case of behavior and development, your history is going to be super important. You'll be able to get to some important conclusions if you can really dig into the problem that's presenting. So we'll talk a little bit about how to do that. It's also important to think about medical history, developmental history. Is there something in the background of this kiddo, maybe prematurity, that puts them at higher risk for conditions like ADHD? What about family history? Is there a strong family history of ADHD or something like autism? What's going on at school? So, all of these little tidbits are going to help you. You also want to be able to do some good clinical observation and exam. Can you have a little conversation with this kiddo? What are those behaviors like that are presenting in the exam room? And can you watch and see how does that parent respond to those behaviors? Are there teachable moments there right there in front of you that could help you in the moment? Obviously, there's a role for screening tools and rating scales. We'll talk a little bit more about that. And if the kiddo is in school, getting some good data from school can also definitely help you sort out the problem. All right. So, how do we start to think about whether this behavior is, quote, within normal limits or not? So, first, it's important to understand what the specific behavior is. Are we talking about hitting or biting or tantrums, for example? Or are we talking about something that maybe sounds a little more serious, like maybe a child that's harming animals? That's a different thing. What about the persistence and frequency of the behavior? So, is this new behavior that's cropped up, say, in the past 3 weeks or so, since that preschool child welcomed home a new baby sibling? Well, you might think about that behavior a little differently than you would think about a behavior that has been going on for, say, 6 months and has been occurring, 5 days out of the week. Are there concerns for developmental delays? So, for example, if we think about biting, biting's really common in toddlers. But by the time you get to, say, kindergarten, we would expect that you're not biting your friends anymore. Although, if you are a child with a really significant developmental delay, it's possible that you may have behaviors that are more in line with that chronologic age. So, it's important to keep that in mind. And then what about the concepts of temperament and goodness of fit? Um, I think this is an important thing to bring up uh, because it can really help a parent understand better and interpret what's happening with their child. So let's talk about that for just a minute. So, what is temperament? Temperament is something we all bring our own temperament to the situation. So what temperament really describes is our emotional style, our ability to adapt. We tend to think about this in children as the sort of easygoing kid who can tolerate a variety of things in their environment, have a pretty easy activity level, or maybe the slow to warm up kiddo. And then, of course, in this context, we're thinking about kids with pretty challenging temperaments who might be even more active, be more intense, be a little moody, be a little distractible. So remember, the parent also brings a temperament to the table. And so sometimes those temperaments fit great. So you can have that super active, wild kiddo. And if you have a parent who also really enjoys that level of activity and energy, that can be a really good fit. As opposed to a child with that same high activity level, but maybe a parent who has a much sort of slower to warm, quieter temperament and really doesn't tolerate that as well. Well, that can set up trouble. And so, if you can help educate families about these concepts of temperament, can help a parent really understand that child's temperament and their own temperament. That can go a long way to making a difference in behavior management. What about temper tantrums? So, tantrums are super common and they are normal. I think it's really important to be able to remind and educate parents about this, especially between ages 1 and 3. And they generally improve with age. So, lots of times we think about the terrible twos, but the truth is by the time a kiddo's turning 3, they have a lot more language and they have some more colorful ways of telling you exactly how they feel about things. So remember, at this young age, developmentally, it's very typical for that kid to be really focused on themselves, to be wanting to get their own way, and really be pushing for that. So again, it can really help to be able to coach parents through this. The tool on the bottom of the slide there is a great little handout that you can find on healthychildren.org that can give parents some really nice tips for managing tantrums. It could be super helpful to use something like that during an office visit to just sort of quickly educate a parent about how you can help to manage these behaviors. So, another really important takeaway from this talk is that behavior is communication. That is just a super important concept. So, young kids may respond to stressful events with behaviors. Young children really might not have the language to talk about the big feeling that they're having, whether that's a positive big feeling or a negative big feeling. Depending on the stressful event that's occurring, the young child may also just really not understand what's going on. But they see those big feelings in everybody else. They have the same thing inside um, and don't know how to express it. And so that can often come out in behavior. So again, this is an important concept to be able to teach families about. And the good news is we can teach young kids to manage stress with some really pretty simple approaches. So again, there's a little tip sheet there at the bottom. Why kids act out, tips to help your child cope with stress. So this also comes from healthychildren.org. It can be a super great tool to use in clinic. So it's important that we teach young children how to regulate. You can do that in different ways. There's some great little apps that teach belly breathing, for example, that preschool age kids love. Um, we can teach kids to do things like take a walk, take a break, maybe go get a drink, maybe a cuddle or a calming activity. It's important to remember that we want to teach kids these skills not during the tantrum itself, but instead during a day or a time when everybody's calm and relaxed. That's the time to teach these types of skills. It's also really important to relate to your child. So, labeling emotions is a really effective strategy, even for very young kids. So, hey, Joey, I can tell you're really mad. You were really mad. It's okay. Let's take a deep breath and let's think about what happened. So labeling those emotions can really help that young child be able to begin to recognize those emotions in themselves. And then problem solving and practicing skills is also important. But again, you do not want to do that in the moment. If you start talking to that kiddo about what is going on in the middle of a temper tantrum, you're going to fail. That's just not going to work. So you want to wait until everybody's calm. Then you can have a good conversation about what's going on. I also think modeling these skills, so coaching a parent that, you probably get upset sometimes too. And that's okay that your child sees you get upset. But then if your child can also see you take a break, take a walk, take a breath, that's going to help your child learn these skills too. So, again, just to kind of summarize a few little tips for parents, recognizing those temperamental traits in both your child and yourself can really help. That can help that parent have a lot more patience. Catch kids being good, that's a great strategy. It's easy to say and it's hard to do. When kids are behaving well, that's often the time that the parent is the busiest, maybe trying to get the laundry done, fix dinner, whatever it is. But if that kid is playing nicely, if you can take a minute to just walk over and pat him on the shoulder, great job, I love how you're playing, and try to make those positive moments outweigh the negatives. That can go a long way, can be very effective. Distraction and redirection are great techniques at this age. Um, Also, choosing your battles is very important. Does it really matter if your kiddo wants to wear the particular t shirt they've picked out, right? But we don't want to ignore aggressive behavior like biting or hitting or those sorts of things. We also want to anticipate that child's needs and know the child's limits. So if we are taking that kiddo, maybe that slow to warm up kiddo, into an environment where we know there's going to be a lot of chaos, don't necessarily expect that kid to just jump right in. Instead, anticipate that maybe your child's going to need a little bit of a quiet space to warm up before they're ready to join in. Or recognize when your kiddo's getting overstimulated, and it's okay to help prompt them to take a break and maybe even to leave an event early. And that can be a great way to prevent a problem. Natural consequences, teachable moments. These can be very effective strategies too. So, for example, if you start throwing the toy that you're playing with, the natural consequence is to put away the toy. And once you calm down, we can get that toy back out and you can play again. And then we've already touched on this, but I think modeling your own behavior in a difficult, stressful, or challenging situation can go a long way to helping your kiddo. And then, of course, remembering to take that time for yourself. If we have not done good self care, we're not in a good place emotionally, then we're going to really struggle to respond the best way to our kids and to our kids' behaviors. All right. So taking it to the next step, it's important to think about the use of developmental and behavioral screening in this context. So hopefully you're doing a good job of doing developmental surveillance at every visit. So remember, developmental surveillance you might use a milestone checklist to do your surveillance. Surveillance is definitely having a good conversation with families, asking them about what their concerns are, thinking about those different developmental domains. But developmental surveillance alone is not enough. We know that if we don't do formal developmental screening, we definitely risk missing kids who might need additional assessment or intervention. So remember, AAP recommends that formal screening at 9, 18, and 30 months, and autism screening at 18 and 24 months. I think in general, in pediatrics, we are doing a much, much better job of implementing these things, and we're catching kids earlier because of it. Remember, there's also a recommendation for behavioral, social, and emotional screening annually from birth to 21 years. So this is just a reminder that if we aren't using formal screening, we will miss kids. Even very experienced pediatricians may not necessarily recognize in a brief office visit a developmental concern that is present. And a parent may or may not necessarily recognize that concern. And that's why the use of the tools are so important. Screening Tool Finder through AAP is a great place to go look at a variety of screening tools that are out there. The tools that you're going to use are going to vary depending on your practice and the resources available to you. All right, so let's get back to our case. So you remember that you're treating Joey's 7-year-old brother for ADHD, and mom reminds you that they have a cousin with autism. You've done a great job with developmental surveillance at each visit. Mom has not mentioned behavioral concerns before, but she has worried that he might be behind in his speech. You review previous developmental screening results. He passed his MCHAT at 18 and 24 months, and you've been monitoring communication, which has been borderline in the past. All right. So let's talk in a little more detail about developmental delay and developmental disability, and a little bit about the differential diagnosis in this area. So, again, we really want to be identifying kids with or at risk for developmental delays and disabilities. You're going to do this using your great surveillance and screening approaches. And then, if we find the problem, we need to be making appropriate referrals. So, remember, from ages 0 to 3, super important to refer to early intervention. Sometimes pediatricians might be hesitant to refer to early intervention. Maybe you feel like you don't hear back from early intervention. You're not sure what's sort of happening within that program because there is this gap between our educational system and our healthcare system. But remember, what early intervention can do is really provide great coaching for that family in the natural environment. So, in that child's home, they can sometimes go out to the childcare setting as well. So, that's a super important piece of early intervention. Early intervention can also help later to link that child to their developmental preschool program through their local school district when they turn 3. So that's another reason to make sure that you're making that referral to early intervention. And of course, early intervention will do a formal developmental assessment to determine if that kid is eligible for services. And that assessment can be super helpful to you also as you think about next steps for this kiddo. Don't forget that after kids turn 3, we can be referring them to their local school district where they may qualify for an IEP and developmental preschool programming. They may qualify under developmental delay, language problems, or even behavior problems potentially. Depending on how the kid is presenting, you may also want to refer for some private speech therapies, OT, or physical therapy. Um, Also, please make sure in kids that you are worried about developmental delay or disability that you are screening hearing and vision. We do not want to miss a sensory disorder like a hearing loss or a vision loss. And then, of course, depending on the presentation, you may want to refer that kiddo for additional diagnostic evaluation. So let's run quickly through differential here. So, global developmental delay, the definition of a global developmental delay is a significant delay in two or more developmental domains. We are typically talking about kids under the age of 5 when we are using this terminology. Um, you can't make a diagnosis of global developmental delay just using a screening tool. You really need to be using that norm referenced, age appropriate, standardized measure. Might be something like a Bailey or a Battelle or a Mullen. So, again, if you've referred to early intervention, that program will complete that assessment and might be able to help you with this. Global developmental delay can potentially predict a future diagnosis of intellectual disability. Um, the more significant the delay, so especially a kiddo who's delayed, say, by 50% in multiple domains of development, that's a kiddo who probably is at higher risk for delays that are going to persist and a potential diagnosis of ID. More mild delays, however, can be transient. And so we recognize that this is a pretty broad term, and we can't necessarily predict outcomes based upon a presentation of global delay at this young age. So, what about an intellectual disability? So, kids who are going to have an intellectual disability, again, typically will present in infancy or early childhood with significant developmental delays. We are not typically going to diagnose an intellectual disability until over age 5. We do need to be able to do a reliable measure of IQ. Um, but again, the big takeaway here is that remember, we do not diagnose intellectual disability based on IQ alone. While we do need that measure, we also need measures of adaptive functioning. We also need to have an understanding of how this is impacting this child functionally, and how many sort of supports, or what is the level of support that might be needed to support that child. And all of that information together is how you're going to be able to make that identification of an intellectual disability. So, specific learning disorders are going to present typically in early elementary school. So, you tend to think about this as the kiddo that is struggling in second grade and into third grade, maybe around age 7 or 8, that we can really start to pick these up. So, again, you may notice some delays or challenges in early childhood. Um, a good example is kids who have early speech and language delays or concerns can be at higher risk for future reading problems. So you might want to keep that in mind as you're monitoring development. So we can see specific learning disorders in reading and written expression, and in math. And again, this can affect, it's not uncommon, 5 to 15% of school age children, depending on the population that you're looking at. And most are going to experience difficulties in reading, or dyslexia. And like all of these other conditions, a learning disorder can definitely co occur with other emotional and behavioral disorders. So, again, a classic scenario would be maybe a young child in whom you made an ADHD diagnosis. Treatment had been going great, and they start to get into second grade and third grade, and things are falling apart and they're really struggling. You can't sort of figure out why. You might want to look closer at their learning. And again, schools can really help you to do that. All right. So, really quickly, what about autism? Autism is a neurodevelopmental disorder. It is typically going to present in toddlers and preschoolers. I think it's really important to remember that autism impacts social communication and social interaction. Sometimes I think folks think about autism when they're seeing big tantrums, challenging behaviors. Maybe my kiddo flaps their hands sometimes when they're mad. Maybe they have sensory differences. Well, that's true. All of that can occur with autism. But if that young child does not have difficulty in social communication and social interaction, they don't have autism. So, social communication and social interaction in a very young child. A great example isn't a child who maybe has a speech delay or isn't yet able to use their words to communicate. Um, they might use a strategy like pointing and grunting, looking at you, looking at the thing that they're trying to show you. That's a great example of using my eye contact, all coordinated with my gestures, my vocalizations, and that is an example of a strong social communication skill. So, again, young kids with autism have to have difficulties in social communication and social interaction to make that diagnosis. All right. So, what about Joey? Let's get back to our case. So, you reassure mom that you're not worried about autism. He has typical social communication development, and there are no concerns for restrictive or repetitive behaviors. You review 3-year communication milestones. He should be able to take at least 2 turns in conversation. Others should be able to understand him most of the time. You administer a developmental screening tool and you determine that further assessment may be indicated. You suspect his speech delay is impacting his behavior, and you refer to speech therapy and also to the local school district for evaluation. All right, so now let's talk about emotional and behavioral disorders. So it's really important to remember that for something to rise to the level of disorder, it must significantly interfere functionally for that child. So kids with emotional and behavioral disorders, they have difficulty with social interactions. If I'm a super impulsive hyper kid, I'm going to have some trouble getting along with my peers. I might do something like run and into my friend and shove them down, and I'm going to have a hard time making friends if I'm behaving that way. Emotional and behavior disorders definitely impact parent-child relationships. That's often why families are presenting to you. They're exasperated. They don't know what to do with their kid. Young kids with these types of disorders, it can affect physical safety, and that level of concern can sometimes influence your treatment decisions in this age group. And these can definitely affect a child's ability to participate in childcare. These might be the kids that are coming to you with mom sharing that the kid's been kicked out of 3 childcares, for example. I think the good news in all of this is that if we can provide access to early, high quality evidence based intervention, we can actually reduce the risk for a disorder to be developed. So there can be some prevention here. And we can certainly help these things become more mild, much more manageable. And can really have some protective effects in the long run if we can get kids access to appropriate services early, which of course is why we're doing this talk today. So, this is just a reminder that whether you're thinking about the developmental concerns um, and or social emotional and behavioral concerns, you have to keep all of this in the context of the psychosocial considerations of that family. Um, So remember, if there are concerns going on related to, say, housing, food security, those sorts of things, that's going to be a family in a highly stressed situation. Again, the child may not have a good understanding of these concerns, and you may be seeing behavior. Well, you're not going to help that behavior until you address some of these underlying psychosocial challenges. Thinking about caregiver health, right? And is that caregiver physically healthy? Do they have access to the mental health care that they need in order to be there for their child? You can also help that parent identify those things that can promote resilience in that parent and in that family. Um, Typically being positive relationships, right? Helping that family to identify that support system can make a big difference. And then, of course, all of these challenges can really impact that child's mental health. It can affect how they're performing academically, social relationships, all of it. So, again, if you're going to remember to screen for and identify these concerns, you want to make sure that you've identified those resources in your community that you can point families to when they need help in these very important areas. All right. So, what about ADHD? ADHD is super common. You will manage these kids in primary care. Again, the prevalence of the condition varies a little bit depending upon the study and the population that you're looking at. To make this diagnosis, you need to document and determine that the kid has actually met those DSM-5 TR criteria for ADHD. So age of onset, we think about this in kids as early as 4. It's part of why we're doing this talk today. You can use DSM-5 based rating scales to help you. So obviously the Vanderbilts are super common. That's probably what most of you are using. But this is my little pearl to to remind you to interpret those rating scales in context. So I'm sure you've all had the experience of collecting those rating scales. You know, the parent form comes back and it's just threes up and down the board. Maybe you get something from the teacher and it looks much less clinically significant. That doesn't necessarily mean that one person is telling an untruth. It doesn't necessarily mean that the problem isn't there. You have to think about the context in which that information is being given to you. So perhaps that parent is super stressed at home. Maybe she's a single mom, and those behaviors for her really are bigger and more problematic. Maybe that child is spending only about 2.5 hours in a preschool classroom in a highly structured environment where those behaviors just don't quite rise to the same level of severity, largely because that kid is getting a lot of structured intervention, for example, that is just not what's happening at home. So again, that doesn't necessarily mean that it's not ADHD because that teacher form didn't rise to that level of concern. So again, you've got to be really thoughtful in taking your history and trying to understand what is happening in all environments. So this slide is just a list of the 9 core symptoms of inattention. Um, you should determine that the kid has 6 or more of these for at least 6 months. So again, that goes back to that duration of the problem. A kid who's struggling with behaviors for maybe 2 or 3 weeks, that's something different. That's not going to rise to the level of a disorder. And I think the other key with the symptoms of inattention, and I'll show the ones of hyperactivity and impulsivity in a minute, um, but these symptoms also have to affect them at a level that is inconsistent with their developmental level. Um, so we expect a younger kid to have a shorter attention span, right? We don't expect a 3-year-old to be able to sit as long doing some sort of a pen and paper task, for example, compared to what we might expect to see with a 6-year old. So it's important to keep all of this in context. These are the 9 core symptoms of hyperactivity and impulsivity. So again, the same kind of concept here. You want to determine that the kid has 6 or more of these. This has to be pretty persistent. So it's something that's been causing problems for a long period of time. And again, inconsistent with developmental level. So a kid with significant developmental delay is probably going to have more immature behavior and a shorter attention span. So you just want to keep that in mind. Um, I think one other quick comment about symptoms of ADHD. Young kids who are going to go on to potentially have a diagnosis of ADHD often are the kids that are presenting with super problematic behaviors in preschool or in childcare. And kids with those hyperactive and impulsive behaviors, those are the kids that we are most likely to identify because the behavior causes a problem, and everybody pays attention to that. It gets attention. These are the kids that are going to present to you. Kids with more inattentive type ADHD, that tends to present when kids get a little bit older. That is that kind of daydreaming, spacing off, um, might are tend to be kids with a lower level of behavior, and so they can definitely fly under the radar. Those are kids that are much more likely to get missed. So that's just something important to keep in mind, again, when kids are presenting to your practice, maybe struggling in school, and who haven't come to your attention earlier on. Maybe that is a kid with a more inattentive type presentation. All right. So again, we're focusing on preschool age kids. So let's talk for a minute about ADHD in kids who are 4 and 5 years old. So it's really important before you make a diagnosis to make sure that we have given that parent some of the teaching and coaching and tools that they might need to manage behavior in that child. So, specifically, we want to be recommending parent training in behavior management. We're going to talk a lot more about that in a minute. Um, you should be very hesitant to make a diagnosis of ADHD in a young kid if you have not given the parents these strategies first. These types of strategies really can be potentially preventative. If you have a kid with significant ADHD at this age group, you really might consider referring to the school district. The district may or may not determine that that child's eligible for services, but they may be. Um, Once you have given these great recommendations, that's when you're going to think about getting those parent and teacher forms. You're going to be thinking about that DSM-5, and then you may take the steps to make an ADHD diagnosis in this age. I also want to point out that the Society for Developmental Behavioral Pediatrics has published a clinical practice guideline for the assessment and treatment of children and adolescents with complex ADHD. So, what do we mean by complex ADHD? It's partly defined by age. So, there are times when it may be appropriate to make a diagnosis in a very young child, as young as age 3. But again, you should be very careful doing that, and you want to make sure that you really have a solid understanding of what's going on with all of the factors that we've been discussing today. So, diagnosing ADHD under the age of 4, that's when you might get a subspecialist involved, like a developmental pediatrician. Or perhaps a child psychiatrist or other mental health professional. Um, Complex ADHD can also be ADHD diagnosed in the context of other coexisting conditions, maybe like autism or an intellectual disability, or ADHD that's just really quite severe. Or again, as we've mentioned earlier, if you've been managing that ADHD, something I haven't commented on yet is that management of ADHD is really super satisfying. For most kids, you can make that diagnosis. In a school age kid, you try maybe one or two medications and they get better, and they do great. It's a really fun thing to manage. And so when you have those kids that you're treating, you're taking all the right steps, you just can't figure it out, they're not responding to treatment, that's when that thinking cap needs to go on because there's probably something else going on. And so, again, you may be able to identify a co occurring anxiety disorder or something like that. You may also need the help of another professional to identify, say, maybe a learning disability. So, what about the disruptive behavior disorders? So, oppositional defiant disorder, that can definitely present in this age group. But the caution that I want to give you, again, I would make sure that before you decide to use a label like this, especially in a very young kid, that you have gotten that parent the support they need to learn those behavior management strategies. Oppositional behaviors can respond really, really well to appropriate behavior management strategies. And in fact, it may be that those behaviors really get better. And guess what? It really wasn't a disorder at all. As kids get older, if those oppositional defiant behaviors really are present and quite intense, significantly impacting that child's functioning, then it really may be appropriate to go ahead and identify that diagnosis. And then it's going to be a process of helping that family understand this is not the kind of thing that's going to respond to a medication, but there's going to be a really important role for counseling and therapies to help address this challenge. So, what is conduct disorder? Conduct disorder is not the same thing as ODD. Kids who have ODD that persists and is significant may be at higher risk for conduct disorder in the future. But conduct disorder really means young people who are having behaviors that are really outside of the sort of societal norms or rules. Maybe they're stealing cars. Maybe they are hurting animals or assaulting other persons. These kids really don't do very well, and can have really poor outcomes in terms of their academic achievement. These are individuals that are at high risk for things like incarceration. And I think the reason to talk about conduct disorder here is partly to make sure you understand what it is, but also just to reinforce the importance of identifying these behavioral challenges early on, getting families the supports they need to manage behaviors, because this is something that we can potentially prevent. So, what about the anxiety disorders? First, anxiety disorders are super common, and they occur in preschool age kids. But in preschool age kids, those kids are not likely to be able to tell you, gosh, I'm feeling anxious or worried. I'm feeling nervous. I feel like I have butterflies in my tummy. I'm feeling sweaty. They're not going to be able to articulate those symptoms. So instead, how does it present? It tends to present as behavior. So again, it's something that you want to keep on that differential. And again, you're going to be relying on observations and data from parents, caregivers, and school. These symptoms can definitely overlap. Again, it's on your differential. I think you also want to think about temperament. So, again, kind of remembering, a kid that is slow to warm up, right, doesn't necessarily have a separation anxiety disorder. They're slow to warm up. Um, Anxious kids, it's not unusual for them to have anxious parents. And so, again, making sure that parent is getting the support that they need so that we can be modeling the way that we manage anxiety. Again, there are screening tools that can help you to identify these types of conditions. And this is just a reminder that ACAP recommends interventions like cognitive behavioral therapy and SSRIs for ages 6 and above. This is a quick list of the specific anxiety disorders. When you're talking about super young kids, separation anxiety disorder is something that can present in this age group. Again, you need to remember that that is totally normal in young toddlers. Selective mutism can also present in this age group. This is pretty rare, but does occur, and preschool age is a common time for it to present. So these are kids who maybe are doing fine talking at home. And then when in social situations, maybe in your office, but oftentimes in the preschool classroom, they just are not speaking, or maybe only speaking very quietly, or just whispering to their parent. Um, so again, this is an important thing to identify because we want to intervene at an early age to maximize positive outcomes for these young kids. And again, this is just a friendly reminder that when we're making this diagnosis, you have to think about how long has the problem been going on and is there an impact on daily functioning? All right, so now we're going to talk a little bit more about evidence based treatments. So, you've probably noticed that we have really not talked about medications yet. There is very limited evidence for psychopharmacological management in kids under age 6. There's a little bit of evidence in ADHD, so we'll talk about that. But despite this limited evidence, over the course of the past several years, we've seen increased rates of prescriptions of medications, including atypical antipsychotic agents in kids who are under the age of 6. This finding is part of what has fueled the energy to make sure that we have access to these evidence-based interventions and behavioral parent training for parents. There may be situations where you live in a community where there really are not, it may not be access to those kinds of interventions, and it's possible that in a very young child you may have some of these challenging behaviors like serious ADHD that's impacting safety, and there may be an indication for medications. But you want to be very, very thoughtful about when you choose to do that in young kids. So again, non-pharmacologic therapies, those are first line, and they can really be preventative. I think it's also important to know that just by being familiar with these approaches for young kids, you can actually go a long way to reducing barriers to access to these services for kids. So let's talk a little bit about some of those barriers. There's definitely still a lot of stigma around mental health. Parents or even providers might have some biases or sort of core beliefs related to mental health. I think the way that we counsel about these therapies and the language that we use as providers can really impact whether or not a parent is going to buy in and participate. So if your approach is, oh my gosh, Joey's behavior is just unacceptable. This is ridiculous. And you just write a prescription for an intervention like Triple P, hand it to the parent. You just need to go do this program or this is never going to get better. That is going to flop. There's no way that that parent is going to buy into that recommendation. Um, so instead, your approach, making sure that you're really listening to that parent, that you're empathizing with the struggles that that parent is having with their child's behavior, and then that you're able to talk about these therapies in a way that helps the parent understand, parenting Not easy. And parenting kids with significant behavioral problems is also not easy. And we are not naturally born knowing how to do that. We all need help to learn those concrete strategies to make it better. And the good news is there are programs out there that can teach you these specific strategies and provide you ongoing support. Yes, it's true. We do lack providers. That's absolutely true. That doesn't mean, however, that we shouldn't be pushing to get families enrolled in these programs. Payment can be an issue. Um, we also know that we really want to push for these co-located and integrated primary care and mental health models. Hopefully, some of you have this integrated within your practice. We also know that some of the important things that we can do, care conferences, care coordination, observations, some of those things can be a challenge to do, again, because of reimbursement and time. This is just kind of a neat little graphic from the CDC. This is an example of something that you could hang in your practice to help parents understand what we mean when we talk about behavior therapy. Having materials like this all over your practice can really normalize. The idea that we can all really benefit from these types of interventions. And again, it can reduce the stigma and the barriers to families who may be hesitant to participate. This is another graphic from the same CDC resource that, again, just can really help parents start to understand kind of what can I expect in behavior therapy? What are some of the outcomes I'm looking for? What are some of the strategies I'm going to learn how to use? And I think it can help you remember kind of how to communicate and how to talk with families about these interventions. Because as a pediatrician, you can really have a powerful voice in convincing families that participating in these things can make a big difference. So, what is parent training and behavior management? Um, these kind of strategies really engage parents, educates parents. Parents are partners with the therapists in these programs. Um, Again, we talked about this earlier. These programs really teach parents how to reinforce positive behavior. That sounds so simple, but it is so hard to do, especially when you're in the middle of busy, stressful life. It teaches parents helpful strategies for ignoring some of those just annoying behaviors, maybe attention seeking behaviors. Again, that can be really hard to do. And so, providing families supports and strategies for how to do that can make a big difference. These programs will also teach parents um, how to respond to an unacceptable behavior, right? So we know that spanking or corporal punishment, for example, is really not an effective way to do that. But instead, understanding strategies like appropriate use of timeout and programs can teach parents things like, gosh, timeout doesn't just mean sit quietly in the chair for 4 minutes. Timeout is really removing the child from whatever the situation was, allowing that child to calm down. Once that child's calmed down, we get to reintegrate. And again, the point of a timeout is really to teach that calming. It can be very powerful to teach parents strategies for implementing that appropriately. This is just a little bit more about parent training and behavior management. This kind of training also really teaches adults how we can kind of influence the environment that's going on, maybe the structure of the day to make a difference in child behavior. Parents who go through these programs really feel empowered. They really have a much better handle on how to understand their child's behavior and intervene. And when parents have that power, when they feel like they know what to do, they're much more likely to respond in a positive way when that kid's behavior gets hard. And again, we've said this 1,000 times, but the effects of these programs really do persist. These are some examples of evidence-based parent behavior training programs. Um, all of these programs are available in Ohio. This is just a little plug that Triple P is offered online to Ohio families for free. That is through Ohio Children's Trust Fund. Not all of your families would probably benefit from doing this kind of a program online, but some of them may. So it's a great resource to be aware of. All right. So you are going to notice that this is basically the one and only slide where we're going to talk about medication. So, again, if you've diagnosed ADHD in a preschool kid, first line treatment is that parent training and behavior management that we've been talking about. And maybe also some behavioral classroom supports. So, again, this is where that school district might get involved. Or making sure you're sending kids to Head Start programs. They also can do a really great job of supporting kids with these kinds of needs when appropriate. So, what about medication? So, if we've done a good job of getting all these great supports in place and that kid's ADHD is really still impairing and there are functional problems, then medication is indicated. Um, so the interesting little tidbit here is that the dextroamphetamine products, or Adderall's, the brand name that everybody thinks of, those actually have the FDA approval as young as age 3. So it may be, if you're treating a kid at a preschool age, that you need to start with a small, short acting dose of Adderall or dextroamphetamine, simply because that's the one that has the FDA approval and that's the one the insurance company is going to approve. However, there's evidence in preschool age kids that methylphenidate is actually a preferred product, tend to have fewer side effects, a little less irritability, and that sort of a thing. So AAP really recommends methylphenidate as a first step, or Ritalin is the brand name that everybody thinks about. Um, but again, you may not be able to prescribe that first. You may be stuck prescribing the dextroamphetamine first because of insurance issues. So if I'm working with a family, I tell them all this stuff because I think that it really helps a parent if they understand, gosh, I'm picking this. Here's why I'm choosing it. Here are the things that I worry that could potentially happen in terms of side effects. Your kid might do great on it. But if your little 3-year-old gets super irritable, super emotional, super aggressive, don't worry. We're going to stop that medication. We can stop it right away. There'll be no lasting, concerning effects, and we're going to try this other one next. So as much counseling as you can do about what to expect. Again, you're a lot more likely to be on the same page as families and to have families who really go ahead and follow your advice and don't just sort of stop and give up on the medication if it doesn't go well. They're more likely to reach out to you, talk to you about what happened. So I think we've driven this point home. Medications are not appropriate for children with hyperactive and impulsive behaviors who do not fully meet criteria for ADHD. But remember, recommend those behavioral interventions like parent training and behavior management. So let's get quickly back to our case. You identified concern for speech delay, referred to speech therapy, and suggested evaluation by the local school district. You know mom needs help with behaviors too. You educate mom about parent training and behavior management. You explain this intervention can potentially prevent development of behavior disorders. You also acknowledge that there is a risk of ADHD for Joey, and you agree to monitor going forward. You counsel a bit about temperament, temper tantrums, and you provide mom with some great resources from the American Academy of Pediatrics to help. Mom feels relieved, thanks you for all the great information, and she feels confident about what to do next. Here are just a few resources. Again, definitely check out some of the great parent handouts at healthychildren.org that I think can be great to use in a busy practice. AAP also has some great information related to topics such as social emotional development and protective factors and autism spectrum disorder, um, with all sorts of resources there for you. I mentioned the screening tool Finder. Definitely check out CDC. They have some wonderful materials they've made related to those new developmental milestones that could be great to use in your practice. 0 to 3 is also a great resource for great information about social, emotional behavior and development in this age group. All right. I'm going to send us back to Mark to help wrap up. Thank you all for your attention.
Thank you. I just want to mention real quick before we close that there are some companion resources that go along with this presentation on the Ohio AAP's website. And then say a great big thank you to Dr. Foster for a wonderful presentation today, full of really great information that is available on our website as well. We hope that you all have a great day. And once again, thank you for attending.
Thanks.